Okay, good afternoon. We will get started here right on time as folks start to filter in. We are excited about our session this afternoon. I am thrilled to introduce you to Daniel Kuzmanovich. He is a researcher, speaker, and facilitator at the advisory board, where he conducts best practice research on physician enterprise strategy and operations. He's especially interested in the intersection between technology and the practice of medicine. Before he was with the advisory board, he developed health education content at the Center for the Study of Human Health, and he graduated from Emory with a bachelor's in arts degree in history and predictive health. Daniel is with advisory board, like I mentioned. They've been a tremendous partner organization throughout the years with us, and we're always lucky to have speakers join us from that organization. So today we're thrilled. We'll jump right into it. Daniel, the screen is yours.
Well, let's see if I can play the 2020 game of bingo and make sure I get my screen sharing, I'm not muted, all the fun stuff that comes with this game that we all have in the virtual world. I'm also going to try to open a chat function, or perhaps Mara, you can make sure I have chat feeding back to me. There's the chat. Cool. Awesome. First off, thank you everyone for being here. Thank you for having me. I promise I will do my best to not be one of those boring, disengaging folks that is just going to show you slide after slide for the next hour. I know we've all been a part of presentations like that and been a part of sessions like that. As much interaction as possible. So please feel free to use the chat. Thank you to Mara and Megan and the entire team at the Jewish Healthcare Foundation for two things. One, having little old me and the advisory board represented here today. Two, what an incredible event. 2 weeks, virtual conference, bringing together folks in this space, in this market in Pittsburgh. Wow, quite the accomplishment. My compliments, and I'll probably take some notes over the course of how you all have done this, because the advisory board is sort of in the event business in healthcare too. For those of you who may be less familiar with the advisory board, we are a healthcare industry research firm. Some people would sometimes say think tank. The way I kind of explain it is we are between consulting and academia, studying the problems that exist in healthcare and the solutions that healthcare constituents, be they vendors, people who have, for instance, telehealth platforms or remote patient monitoring, suppliers, thinking about people who provide testing or vaccines, that's a popular topic these days, or provider organizations themselves. When it comes to that very wide ecosystem that is healthcare, I look in the industry kind of at two topics that have been referenced: the physician's piece, care delivery, and technology. Funny enough, telehealth seems to cut right across both of those. And that's why I am excited to have, very much as possible, a conversation. So the chat is open on my screen. Please submit it with anything you might want to talk about, hear about, what have you. I don't claim to have all of the answers, but the advisory board has dedicated, as you might imagine, a ton of time studying telehealth for years, and especially this year. What I'd love to do is have a little bit of this conversation, in particular about how COVID-19 has transformed telehealth, where it is today, and where it is going. And what I thought might be nice for those of you who are with us is to make it easy. Takeaways. I've pulled out the 5 takeaways that I would consume from this if I was listening. The first one, and this is really surprising because people have, especially in the healthcare industry, when I think about the provider organizations I so often find myself on the phone with, they have defined telehealth very narrowly as virtual visits, when I would be willing to bet many of you all in the conversation today are thinking about telehealth much more broadly. This is my big message. This is my big takeaway. Telehealth is much more than virtual visits. Right now, healthcare is very much focused on, I can pick up this device and turn on a camera and see my physician. And that is definitely an aspect of telehealth. But what telehealth is and what its potential to be is much more than that. The second message that I think is really important for folks across the healthcare industry, whether you work in the creation of products, whether you work in the community, whether you work for a provider organization, to realize and internalize, is that telehealth is here to stay. One of the ways that we have articulated this very much to a lot of our provider institution clients is it is a must not lose. You need to have a telehealth capability. You don't have to have the world's best telehealth capability, but patients have joined in and found great value in telehealth. And for that reason alone, we think it's here to stay. And from a provider perspective, they must not lose. This other one, I'd be willing to bet that there's a lot of questions that you all have encountered when you think about telehealth as it pertains to, well, how long is it going to be paid for? Who's going to pay for it? Does the patient pay for it? Does the provider organization pay for it? Is it allowed? One of the big challenges right now is reimbursement. You know, telehealth during the public health emergency has been paid at parity, consistent with, you know, I will get paid if I am delivering healthcare the same as a physician would be paid for an in-person visit if I am that physician and also do it virtually. That has not been the case up until now. What happens with payment long term? Regulatory is also important here. Is telehealth continued to be allowed via certain devices in certain settings? The way I sometimes think about this is kind of, for those of you who have kids, I suspect this image will harken back to your fond time raising them, is the first time your kid tries to make pasta or rice or mac and cheese or something, and they go to boil the water and then they pour in whether it's the pasta or the rice. And then from then on, they struggle to find the right balance. Is it too hot and the pot boils over? Or is it too low and it's, you know, dinner's not going to be ready until next week? That's some of what's going to happen with telehealth regulation and reimbursement. This is a brand new burgeoning regulatory challenge, or at least the aggression that has been put on it from a momentum perspective by 2020 very much calls out, hey, we're going to have is, and there's going to be a learning period. It's going to be a learning period for provider organizations. It's going to be a learning period for vendors who are creating different telehealth products, for patients who are using it, and for regulators who are, you know, saying who can do what, where, when, and how. This fourth one, I think, is especially geared towards people who would use telehealth to solve a business challenge or have a telehealth offering. So thinking about some of the providers that might exist in the Pittsburgh market, UPMC being one of the most notable. It's not a strategy. When people talk to me about having a telehealth strategy, I am that person who is like, I hate to correct you, but telehealth is not a strategy. You shouldn't have a telehealth strategy. What you should be doing is using telehealth to solve problems. If I'm imagining I'm someone creating a telehealth product, or I'm someone who works for a telehealth company, that's also a really valuable piece to internalize. How do you position your product in a way that it solves a business challenge in healthcare, whether it be it for a patient, for a company, for an employer, for a provider institution? And the last one, I recall a line that I dropped in February. In February, I was up in the Northeast. I was talking about telehealth. I was working with a provider institution that was making its 5-year, 10-year plan as it pertains to telehealth. And one of the lines that, you know, I routinely have come to is, in 10 years, we're not going to call this telemedicine. We're just going to call it medicine. And that is very much true. But if we don't do a good job with this, someone else will. If provider institutions don't do a good job with telehealth, if they treat it as a, you know, we don't have to have a product or an offering there, then some other provider will, or some other constituent will. Employers right now are very interested in telehealth because, hey, this can allow me to keep my employees at work and have them not have to take half a day to go to the provider clinic, and also not potentially risk COVID exposure. So these are some of my main takeaways. I hope that this alone is like, oh, I get what he's going to talk about. Now I'd love to kind of tell the story as it pertains to telehealth. Where was it? Where is it? Where's it going? I don't see any questions or comments in the chat as yet, but I would ask folks to please put as many in as you can. I love making these as interactive as possible and tailoring them to your particular purposes and goals. And Mara, Megan, if there is something that you're thinking about that's worth calling out, please push me on it. Put it in the chat. Let's start with the definition of telehealth. I always like to start with the definition when people talk about a terminology or a new word or something, because it's like, okay, let's get to that first message that telehealth is more than virtual visits. I think this definition in the middle here does a great job of encapsulating the full suite of pieces that make up this very important and potentially industry changing force. It is the interactive electronic exchange of information for clinical purposes, for purposes of diagnosis, intervention, care management, between patient and provider, or between provider and provider. When most people think about telehealth right now, today, they think about the virtual visit, this patient to provider component that is synchronous. It is real-time interaction where I can hop into a Zoom, a Skype, a Teams, a WebEx, pick your platform of choice here. Google, I think, has one as well, Google Meet, trying to be equitable with this. Pick your platform of choice, hop in and have that conversation. But that also exists on the other spectrum as well, right? Imagine a patient goes to see their primary care physician, and that primary care physician is unsure what's going on. That primary care physician could potentially refer that patient to a specialist, or they could do what we have here, a provider to provider use case, where they have an e-consult. And if I have a cardiologist colleague that I want to loop in and say like, hey, can you help me make sense of what's happening with this patient? That too is an example of telehealth. Spectrum Medical Group in Grand Rapids, Michigan does a great job with this. We profiled them way back in 2018, which feels like 50 years ago, not 2 years ago. I don't know if I'm the only one that feels that 2020 has dragged on a little bit, but they have that capability. And that doesn't even have to be done synchronously necessarily. That doesn't have to be a real-time interaction. Sometimes that can be, what we would think about down in the bottom, a second opinion consult. Sharpry Steely, primary care physician, can put information into the EMR, it goes to the specialist, and the specialist physician can give them that second opinion consult. It's kind of like, hey, I just got a quick question. Can I swing by your office? But it's done technologically. And there's a lot of demand for things like that because it really reduces some of the access problems that exist in different specialties. But if that's the patient and provider piece of this, there's also a lot of other cool things. I am especially fascinated by wearables and home exams and implantables. For example, home exams are huge this year. Doing health screenings, doing telehealth where you're exchanging clinical information, exam is sent to you, you take that exam, it's fed back to your provider, and then you have that virtual visit. That is an example of remote patient monitoring. Implantables. There's a company called Proteus. They had an interesting experience where they were about to file for bankruptcy, and then I think they got purchased. But Proteus, a couple of years ago, had created a pill where you take this pill and it will feed information back to your physician about your status after a surgery. And then secure messaging, which sounds surprisingly low tech, but is really valuable. A patient being able to take a quick picture of, hey, doc, I saw this thing that, has concerned me. Can you take a look? And sending that to the physician saying, I think you should probably get a dermatologist appointment. Oh, no, that doesn't look malignant, or we should meet face to face. All of these are telehealth. So when people think about virtual visits, they are not wrong. When the virtual visit focus that we have seen just sweep healthcare is going on, people are not wrong. But there's a lot of other cool stuff happening here. And in the future, there's not to steal ahead of my own thunder here, but as virtual visits are figured out, these other things have some really impactful power to transform how we deliver care. That is my first big message. Telehealth is more than virtual visits. It's actually a lot more. I have my first question, and I'm gonna do my best to read it and answer it. Challenges with expanding or revising policies to support telehealth, ensuring HIPAA compliance, documentation in the EMR. Do I have thoughts on this? Yes, I do. COVID seems to have accelerated healthcare organizations to conduct these necessary policy changes. Will it continue? What an excellent question. And it's not a plant either. Where we were, you are a perfect segue, so I'm going to take that opportunity. Let's talk about how that happened. Where we were pre-COVID, when I was talking to that institution in the Northeast about their telehealth strategy, 1 in 4 healthcare organizations in the United States had telehealth. They had a virtual visit capability. They had it because it was this cool offering that they wanted to be able to provide to patients. But nobody was really making a lot of money off of it. 1, because of reimbursement, and 2, because of this important thing: policies, not just organizational policies, but regulatory policies. Policies, hey, you can't be in New Jersey and see a patient in Philadelphia. You can't be in one state and see a patient elsewhere. You crossing lines, institutions allowing certain people to be able to access telehealth versus not. For instance, advanced practice providers might not be able to provide care via telehealth in the past. Thinking physician assistants, nurse practitioners, these folks, there was scope of practice that restricted this. When CMS declared the public health emergency, CMS is the Center for Medicare and Medicaid Services. They are kind of, the federal regulatory agency. They both cover Medicare and Medicaid from a reimbursement perspective, but the regulations that they issue often become the policy, the nom de guerre for other payers and regulatories across the country. They had a bunch of restrictions about telehealth, these policies that has been alluded to in the chat. And when we had a public health emergency come down and patients could not go access their care, CMS kicked a lot of those down the road. They said all of these are off for the state of the public health emergency. Some of the barriers that they dropped: patients being able to access telehealth from their home rather than having to come into a clinical site to access telehealth where a physician was at another clinical site. Well, you can't do that during COVID. The ability to do telehealth via a smartphone rather than via a secure HIPAA compliant app, to your point, right? They said, hey, you can use FaceTime, you can use Skype, you can even do audio only, which you see on the bottom left. They also said, hey, we actually are going to expand telehealth to everyone. Everyone can get telehealth, new and existing, not just existing patients. Whereas before this public health emergency, the regulation said you could only see a provider virtually if you. They removed some of the benefit components, like you don't have to pay. And of course, they made all providers eligible. Those nurse practitioners and physician assistants and more were allowed to access telehealth and provide care via telehealth. Those were the barriers that they dropped. One of the questions very much on people's mind is, from a regulatory standpoint, from a policy standpoint, what happens when these come back up? Telehealth access will be restricted. And this is the unfortunate truth. When we think about how COVID-19 is transforming telehealth now and in the future, what we have seen is this explosion. We went from, when you drop the regulatory barriers, when you pay for it, suddenly telehealth is everywhere. Of course, there was one other factor that was incredibly important. And that was like, oh yeah, I had no other option. For most parts of the country, I had no other option to see my physician. So I can have a virtual visit instead of going in person, and it's more convenient. Sign me up. Physicians, when they had no other option but to see patients virtually, adopted telehealth like crazy. 1 in 5 physicians had done a virtual visit at the start of 2020. 1 in 4 organizations had a virtual care program at the start of 2020. If telehealth was something that you could buy stock in, just the concept of it, not an actual company, but if telehealth was something you could buy stock in, I wish I had bought some stock, because this thing exploded. 200% order of magnitude increase in the amount of care that has been done. What's gone from being next to nothing has been pretty much 100% of how care was delivered in the March, April, May timeframe. We started to see, though, that dropped off. And this graph on the right is pulled from an organization that we work with, but it's very emblematic of what we've seen across the country. We got close to doing 100% of our care virtually per week across the healthcare industry. And once stay-at-home orders started to go away, those regulations, though they were down, and reimbursement, though it was down, did not keep patients going back to virtual care. Physicians and patients started to revert back to in-person care, leaving a portion of care being delivered virtually, but not nearly as much as could be done. This question on the slide here, how far will virtual visits, the main aspect of telehealth right now, fall? What we have seen is that organizations have gone from nearly 100% of their care being delivered virtually down to in the 5 to 15% range, with most organizations in that 7 to 10 sweet spot. So of 100% of your volumes, you're now down to maybe 1 out of 10 being delivered via virtual visit, which is fascinating because when we at the advisory board look at the data and try to figure out of the care we know how to do today, how much can be delivered virtually? And the answer is 20 to 30%. So said differently, most organizations are doing 1 out of 10 visits virtually right now, but they could be doing 2 or 3 out of 10 virtually right now. This is likely to change as we go into the winter months and as COVID continues to resurge the way that it has. But we are seeing this trickle down back to previous levels is taking place. So I hope that gives you some sense of the answer, right? What they kicked most of the doors open and let telehealth really flow. But now, from a regulatory perspective, those barriers are still down. We have seen, however, that volumes virtually have gone down as people get back to in-person care. But that is not the only piece. The regulatory piece, the policy piece is not the only piece that's really important here. The other one is reimbursement. So Highmark is the dominant payer in the Pittsburgh area. Well, when we look at payers across the country, this is what we tend to see. National payers, people who are saying, I will pay for a patient that sees a telehealth service. Most of them, the United Healthcare corporations, the United Healthcare of the world, the Aetnas, the Anthems, the Cignas, the Blue, those are all pretty silent about what their long-term stance on telehealth is or will be. What we hear from Blue Cross Blue Shields, which are much more equivalent to what I would think of as like the Highmarks, the local health plans. Many of them are quiet, but we have heard some rumors. Blue Cross Blue Shield of Tennessee has said, we will pay for telehealth long term, but they have not said how much. Blue Cross Blue Shield of North Carolina said we would pay for telehealth at parity. You can do an in-person visit or a virtual visit, paid the same thing, parity, until I see a question. I'm going to come to that in a second. Talking and reading are still beyond me. Blue Cross Blue Shield of North Carolina has said they will cover telehealth until the middle of 2021. We have also heard from payers that are saying, hey, we will actually give you, close to parity rates long term, but only if you get into a payment model that we are interested in, such as downside payment, where if the organization spends too much, if the provider spends too much, the organization is kind of on the hook for some of that cost with the payer. And some Blue Cross Blue Shield plans have said, hey, we're not planning on covering this long term, some of the local plans. CMS, the big regulatory agency that most people have followed, has said early at least, they do see telehealth as one-to-one. They do see telehealth as being reimbursed long-term, but probably not in a one-to-one ratio. Telehealth is a big part of Medicare Advantage rule that dropped earlier this year, where CMS is going to bake telehealth opportunities into that option. Adam, I'm going to read your question now. Amount of visits in percentages. 100% of visits in May were virtual, now down to 10. Assume the whole number of visits also imploded May through July, and so did the number of virtual visits increase? And if so, do I have a sense of how much? I'm going to try reading that again. 1 moment, please. Yes, the whole number of virtual visits that we saw across the country dropped across the May to July and even into now timeframe. the number of virtual visits that we have seen has not really increased. We are seeing that virtual visits are above where they were. So if virtual visits were 1%, right, 1% of 100 of a provider's volume, but usually less than that. It was much more of a decimal point than the one, but I'm going to use the one for round numbers. Right now, they have seen an increase of about 9%, right? If we look at the if we look at the year in aggregate, they were at 1%, they went up to about 100, they started to drop down, they could have stabilized at 20 to 30% of what providers were capable of, but where we see them now is closer to 10. So we're still 9 percentage points better than we were in this construct, but we are still at least 10, if not more, percentage points away from where we could be in terms of delivering virtual care. Adam, I hope that answers your question. Cool. Folks, keep them coming. I very much welcome questions as we go. I try to know my stuff and give you an answer, and if I don't know the answer, I will give you a very honest, I don't know. This is the reimbursement question. The regulatory piece is huge because it's going to determine what can be done and where. This is the answer kind of on the regulatory piece. There is a division of control. There was an election this year, surprise. I feel like COVID and so many of the other very real forces have dominated the sphere of, I've got another question, I'll come to it in just a moment. COVID and so many other forces have dominated the sphere of what's been occupying our attention in healthcare specifically. The election, we're still waiting to see what the results might be, especially what it means in terms of the Senate. But what we see from a regulatory perspective is CMS does plan on covering an increased number of services, and they are going to try to figure out how to set reimbursement rates. But the legal function, Congress itself, gets to say who can bill for what, whether provider organizations can bill facility fees in addition to the professional fees associated with telehealth, and where patients have to be when they receive telehealth. So the regulatory question is complicated, but we do believe, based upon everything that's coming out of CMS and what our early hypothesis might be about the Biden administration's healthcare goals, which are mainly to expand coverage, that telehealth really fits into both of those ambitions. I am going to come to, I see a couple of questions, which I very much welcome. We have seen that most of the virtual visits are provider driven. Great question from Valerie here. Most virtual visits are provider driven. There are longer term hesitations, one being staffing. Any successful staffing models to account for on-demand visits and also scheduled in person and virtual. Providers only doing virtuals between X hours. Great question, right in the heart of healthcare practice operations delivery. I will give an answer to that. I am so excited. What we are seeing from a virtual perspective is two schools of thought. One is that virtual must be done separately from the in-person clinic because the mental part on the provider, the mental switching costs of I see a patient in person and then I see a patient via Zoom. Well, we have seen that virtual visits, when they are carved out as a block of time, providers can be more efficient. That does help with some of the staffing problems, but the interspersing them throughout in-person visits, like having the provider doing them in the to in-person followed by a virtual, we have seen a lot of organizations do that to allow for cleaning protocols of their practices and of the physician offices. It's less efficient, but it does allow for some, greater cleanliness, which is still very important with the context of COVID. But by far and away, block scheduling of virtual visits is more efficient. And we are actually seeing some provider institutions where they have enough demand. Fee for service, I think is Mike's question, in the next comment. I'm gonna come to that. Fee for service, if you have enough demand, especially on like a downside risk based model, so like if you have some degree of capitation or you have some degree of downside risk where controlling costs is good, a lot of people are actually creating this virtualist model. I think the group that I think of as leading the market here across the United States is in Texas. And what they've done is they have a 24/7 virtualist model where they have a couple of physicians, APPs and MAs, medical assistants, working together to have essentially an entirely virtual delivery system. Think about like a call center, but rather than doing calls, what they're doing is video visits. visits. Staffing is not just a problem, Valerie, for virtual visits, but a problem for all of healthcare right now. So many people do not have the requisite bodies to take care of the patients in their hospitals and in their practices. What we have seen is more efficient from a delivery system that way. And I'll explain it. A lot of providers feel that telehealth takes more time to actually do the work than in person. And for the most part, they are right if it's done badly. The average in-person visit should consume about 20 minutes of provider and staff time. Right now, virtual visits that are done inefficiently because of mental switching, because bad technology syncing up, patients not being ready or prepared, that time is 45 minutes on average. So 25 more minutes than expected allocated to work. What we have seen works really well for such a situation is essentially dedicating an MA or a support person to work with their physician, and that shift is done entirely virtually, and the MA is virtually rooming the patient, when the physician and APP is virtually delivering care. So yes, there's definitely some efficiency challenges, but those are some of the solutions we're starting to see. Valerie, I hope that gives you a sense of some of the answers to those questions. That's a great set of topics. Mike's question. Isn't fee-for-service payment for telehealth a deterrent from the most important goal of moving telehealth to as a tool within advanced payment within value-based care world? CMS and other payers don't want to institutionalize fee-for-service for telehealth. This is a big debate right now. What Mike, I think, is hitting on is this concept of telehealth as a tool. Is it going to be additive, right? Is it, instead of replacing the demand for care, moving something from an in-person visit to virtual, is telehealth just going to add on rather than doing some demand destruction for in-person care? This is a very real concern for some payers and for some regulators, but we don't think that that's really where they are at right now, frankly, because there was a study from Kaiser in the early 2000s that showed that. But when we are seeing provider organizations looking at this now, most of them still aren't tracking the data to be able to have a clear answer. I think that telehealth 100% makes a ton of sense under value-based care. Under fee-for-service, we still do see a valuable proposition for it. When provider organizations see that proposition, patients see that proposition, healthcare suppliers and vendors see that proposition. The question is just the financing mechanism. Is it additive or substitutive? When I refer to now, is this November or maybe the end of Q3? I would say that's a fair push, Gina. Is this November Q3? Does it take into account the surge that we are currently experiencing, or is it more representing the lull between peaks? When I say now, I'm thinking let's go back to November. Most ironically enough, despite how bad COVID has been about raging across the country, outpatient visits, both virtual and in person, are still fairly high at the levels we expected them to be. So we haven't seen the inpatient elective surgeries have decreased, but outpatient visits very much fall into that category of 5 to 10% being 5 to 15 being done via telehealth, mostly in that 7 to 10% range. And the rest, I mean, most provider organizations that I talk to when it comes to their outpatient visit volume would tell you they're between 80 and 95% of their outpatient visit volume pre-2020. Three great questions. So we've talked a little bit about reimbursement. We've talked a little bit about the regulatory stance. Let's talk about this piece, and that is, frankly, those two are up for debate, though they are frankly outside of a provider organization's control. What happens long-term with reimbursement? The answer is probably something, but probably not 100% of what we would want it to be, what it has been during the public health emergency. Going back to, I think, whose question it was about the regulations, Kylie. Going back to Kylie's question, the decrease in regulatory burden to accessing telehealth is down until the end of the public health emergency. That was extended by the Trump administration back in the what we'll call late summer timeframe. And given what's happening in the country, I don't want to be gazing into a crystal ball. So let's say this is Daniel Kuzmanovich's educated hypothesis, not the advisory board's educated hypothesis. But given where we are and what we're seeing around the country right now, it is likely the public health emergency will be extended again. At least until we kind of begin to get our hands on some things. The vaccine, though, has the potential to change that. So regulatory wise, the regulations are down. Payer wise, there is reimbursement, but we are not sure what the long-term future is. This creates this question. Do I practice the field of dreams methodology if I'm a provider organization, say, if I build it, they will come, and build out telehealth and wait for patients to come and wait for physicians to use it and wait for payers? Or do I wait and see what happens with reimbursement and with the regulatory environment? Ironically enough, in this situation, what we are seeing is that it's much more counter to what you might expect. It's much more the field of dreams approach. Take telehealth, use it as a tool, and build it in a way that solves some of your solutions and some of your challenges. This is the big one right now, being unsustainable, for lack of better expression, virtual visits and the workflow associated with that. I think this gets back to Valerie's question about the efficiency associated with telehealth. Right now, there are definitely some providers who are really good at telehealth and even more efficient at it than they are at in-person care. But that is not the majority of physicians and APPs. A lot of physicians and APPs who are delivering care virtually would tell you telehealth takes a lot of work. The user interface, hopping into whichever platform is being offered, many of them have found that difficult. It can be very difficult for them. It can be very difficult for the patients. It requires that there be broadband if they're doing video visits for seeing the patients. And as I mentioned earlier, right, a virtual visit takes about 45 minutes of provider and staff time. A in-person visit overall actually takes closer to 20. In what we'll think of as outpatient visits, a minute is worth about $2.50. And so that's 25 minutes times $2.50. I'm just going to say 50. I think it's probably more, but my math is not that good. And I learned a long time ago, don't try to do math in front of people if you're not that good. So I'm just going to say 50. So virtual visits, if done inefficiently, can be a result of that, can have a consequence of soft calculation here, but leaving $50 on the table in terms of staff expenditure of time and effort compared to what we're getting in from the delivery of the visit. This is the thing that is within a provider institution's ability to influence right now. And one of our big bits of guidance to provider organizations across the country and to vendors and to people who are working in this space is, let's simplify this. Let's make it much more sustainable for everyone. This is why the virtualist model is coming around, why we're seeing the first creation of a new specialty since hospitalists came into our hospitals. The PCPs coming into the hospitals to truly manage care, as happened back in the, Dr. Bob Wachter from, I think it's UCLA, was, the leader of all of this movement. He's thought of as the founding father there. It's not yet clear who's going to be thought of as the founding father of the virtualist movement or the founding mother of the virtualist movement. But what we do see is that there's very likely a new specialty being created. And if we have people who are good at virtual care and they want to do virtual care, perhaps because of, protecting themselves or their families, or because that's something they're really well suited to, a lot of folks are looking to keep them doing that as a way of kind of providing on-demand care, especially in primary care, and also as a way of allowing other physicians to be providing in-person care. So we are seeing this. There's a way to make it more sustainable by carving out time just for a specific set of physicians, but we are also seeing the efficiency gains come from having an integrated solution and then blocking time on a physician or APP schedule. One of your clinic shifts or one of your clinic days is all done virtually, and I'm going to give you the team that you need, room that patient virtually, and have that care team communication that you need to have that experience for patients be the same as it would be for an in-person visit. Thank you, Mike. Thank you, Mike. I knew I was going to get something wrong. I knew it. There's just too many people in healthcare you got to keep track of. UCSF. They do not like UCLA. I agree. What will the creation of a new specialty, the virtualist, mean for medical education? Are you hearing anything about current training for this? Oh, what an excellent point. The answer is not yet. We're still learning. We still don't know what we don't know virtually. Neurology, for example, is a specialty that is not well suited to virtual visits because some of the things that you need to do for an in-person, for frankly, your first visit with a neurologist, some of the things that they are looking for have to be done in person. You're not going to get it virtually. Today. That's what we know today, but neurology is not a good place for that. But 5 years from now, we might know better. I think that one of the challenges is, medical education in the United States is working to evolve very much so with some of the changes that have happened in healthcare. But we are still a little bit behind the curve on some of that. I think a great example of this is the Dell Medical School at UT Austin. It was the first medical school to be created in something like 40 years. And their curriculum looks very different than the medical school that is more traditional because it's all focused on population health and public health and social determinants of health, in addition to what we would think of as legacy education for family medicine, primary care, things like that. The medical education in the context of the virtualist has not yet caught up, but this is a place that's probably going to be ripe. What we have to first figure out is how does telehealth stick around? Where does it stick around? And how do we learn what we don't even know we don't know about telehealth? All of that is to say, though, we think it's here to stay. From the advisory board perspective, I told you earlier, one of my messages is telehealth is here to stay. Right now, it is good enough to have telehealth. It is good enough, right? You're not losing if you have a telehealth capability. Most provider institutions that we speak with actually have two, right? I'm thinking in the context of virtual visits, but obviously there's a lot more we think about, like remote patient monitoring, asynchronous communication. But most provider organizations right now, especially in the context of the virtual visits, they have two. One that is usually integrated into their electronic medical record and easier to use, and easier to use from an IT perspective. But a lot of physicians are also defaulting towards more simple solutions that are maybe not as integrated digitally, but they are easier for the physician or for the patient to use. Right now, that's where a lot of the virtual visits find themselves in one of those two camps. What is the one that your EMR had or that your institution purchased? But there are also a lot of vendors around the country right now that are creating very affordable, and I'm talking like $20 a license, virtual visit platforms that providers can use with patients. And if the provider finds that it's easier to do that than via the integrated solution, they may default to that and then enter it in on the back end. And that's where we see a lot of providers falling into that category. Hey, we've got to have two, easy to use and integrated. But it is enough to have it right now. Longer term, we're going to need to be more seamless. Seamless for patients, seamless for physicians. I mentioned how inefficient sometimes virtual visits can be. And the other one, this one on the right that I think is really important from a context of the patient promotion. Patients can be influenced by a lot of things, by their health plan, by ads in the newspaper. There are a lot of different ways you can reach a patient. But the number one driver of patient behavior, besides the patient, continues to be the physician. It continues to be the provider that they see. And so promoting to patients both from the institution and creating an environment where physicians want to go to patients and say, hey, you don't have to come in and see me today. We can do this virtually because it's easy for both of them. Those become very valuable. And we think about this telehealth as a long-term, must not lose, must have solution. And we do think that it's going to have to be that. Providers like it, patients like it, payers and reimbursements and regulatory are all figuring themselves out. But if we know that the two big constituencies say like, actually there's some value to this, actually there's some worth to this, it's probably going to stick around. And I think this is one of my favorite data points for alluding to just how much patients like it. And folks, I haven't seen a question come in the chat in a couple minutes. So somebody, we got 15 minutes left. Don't miss the opportunity. The advisory board ran a survey of patients. We've run this survey every couple of years. Just, how are patients changing? There's these millennials. Preferences are different than their parents' patient preferences, which are different than baby boomers' patient preferences, which are different than Gen X and Gen Y. And Gen Z. There's so many patient preferences. So we like to ask, hey, what are your patient preferences? One of the questions we ask in this survey is very simple. If I offered you a virtual visit today or an in-person visit tomorrow, which one would you take? And what we have seen is that in 2017, one third, one third of people would take the virtual visit today compared to the inpatient visit tomorrow. In 2020, two-thirds of patients would take that virtual visit today instead of the in-person tomorrow. That's a 76% increase. But what it shows us is, for the most part, patients really like telehealth. And over the course of the year, they have ironically had better access to their healthcare through the demand destruction that happened during the shutdowns and through telehealth. And access has long been a patient demand that many provider institutions feel they have opportunity to meet. Well, patients are going to shop around for access, and having a virtual visit capability, some form of telehealth capability, becomes really important there. And I like this next question very much. And that is why we say telehealth is here to stay. There is a question, what strategies will guide the rollout of remote patient monitoring? I love this question very much. So I'm going to quickly address this piece of telehealth and then move to that, because we have largely talked about the virtual visits because that's what so many people care about right now. But the market for remote patient monitoring, the opportunities that exist there are staggering. The one thing that we are starting to see emerge when it comes to virtual visits, my final comment on this. Virtual visits, what sometimes are lacking when we have these traditional telehealth visits, is what we'll call the clinical information. There is some of that a provider can get virtually. They can have a good website manner. They can assess you with a certain number of questions and visually. But there are some things that they cannot. Remote diagnostics. Some of the ways that we are seeing organizations resolve that are, what we'll call drive-through phlebotomy. Hey, drive up to our clinic, get a quick blood draw, and then we'll have that entered in, and your provider can review your blood results with you. But we are also seeing a great example of vendors saying, hey, we can help with remote diagnostics. And this is the beginning of my tee up for remote patient monitoring. TytoCare is a vendor. We are not affiliated with them. The advisory board is vendor neutral, but they are a vendor, and what they provide is I'll say it, I had to present physician compensation to an institution that had just partnered with TytoCare, and they were the exclusive provider of TytoCare services in their market. And afterwards, I was like, I'm not going to get the audience to listen to any of me, because what were they doing? Well, the CMO of that institution passed out TytoCare, which is this tablet and the set of tools you need to do to give yourself a remote diagnostic, a remote exam. And so you've got physicians up there, looking down their throats and seeing into their ears in the tablet, and they were not listening to me talk about physician compensation at all. But that's what this is. This is a capability that essentially seems a little magical, but hey, science, not my strong suit, but science has come a long way, and it can feed back clinical information to physicians, providing that remote diagnostics. That is the beginning of collection of clinical information for physicians to act on when the patient is not there. But there's so much more in terms of what telehealth can do. Telehealth can also be automated. This is a company called 98.6, a very clever play on the average human temperature. Most of the physicians for this company are what we think of as shareholders within it, but it's all technology. The relationship patients have is not necessarily with the physicians, but with the technology, where the technology is collecting all of the information that the physician would need to make an accurate diagnosis and then completing the care plan. So all the physicians are having to do at 98.6 is really focusing on diagnosing and treat. But the technology is providing, hey, I can collect all of the HPI. I can collect the clinical information that exists from this patient, offer it up to the physician in a very evidence-based, artificial intelligence algorithm backed, excuse me, I get paid to speak for a living, not that you know it. And the physicians are reviewing what this clinical information is, creating the care plan, and the care plan is then handled and executed by the patient and the technology. What a fascinating concept of telehealth that we are seeing numerous places. 98.6 is one example. Smart Exam, which is a product from Bright MD, is another. And then remote patient monitoring is another piece of this. Like, how do we collect clinical information, not just when we are interacting, not just when the physician wants to? There are so many places coming things that actually can improve patient care. The strategies that are going to guide this are first and foremost, does it solve a business challenge? Whether it's Kaiser or whether it's a small health system in Alabama or a large health system in New York, people will not invest in these telehealth capabilities. And this is not just unique to remote patient monitoring, but to all of telehealth, if it does not solve a business challenge. That's the difference between I bought a cool product and I bought a product that actually means something. The second question is, how easy, from a strategic perspective, how easy is this to implement? I categorize that in three parts. Technologically, right? Health systems have a ton, health systems, independent physician groups, you pick it. They have a ton of technological pressure upon them. Technology is how we get a lot of things done. How easy is it to implement it? UPMC partnered with Zelf. They, I think, helped create Zelf, which is a great example of a platform that creates easy APIs, between clinical technologies and the EMR. Easy integration. That's one piece of this. Another piece of this is physician utilization. I often put physician utilization above patient desire for something, provider utilization above patient desire for a technology when I'm thinking about the implementability of it. Because I think, and I mentioned this earlier, is physicians are the greatest source of marketing. The provider, if the provider says, hey, go to CVS and buy this $20 blood pressure cuff and take your blood pressure every morning, some patients will do that. If a physician can make that prescription or can say, hey, I actually got you this blood pressure cuff and it's going to feed back information to me. So if you're at high risk of a stroke, I'm going to be able to see it every day in your EMR and it's going to give me a ping, but it's not going to be a problem for me. I'm not going to have to do extra work. So if it's easily implemented within or around the physician's workflow and it's seamlessly integrated, that's another big piece of implementability. And the last piece of the strategy in terms of implementability for RPM is the patient piece, especially demand, but also use. And I think that the mental health space from a remote patient monitoring, this is one example, but there is so much going on there, whether it's Silverlight, whether it's MindStrong, there are tons, SilverCloud, excuse me, not Silverlight. Silverlight is for Microsoft. There are tons of things transpiring in the context of remote patient monitoring for behavioral health and feeding that information back to the clinical setting. So the strategies that are going to guide RPM rollout, going to guide this implementability is, frankly, does it solve a business challenge? An A+ implementation with a C+ product will actually work. And that's the second strategy. You have a great product that is easy for people to use, easy to integrate, and actually solves a challenge while being good for patients. Those are the pieces that are going to guide it from a rollout perspective. I love that question. I am very passionate about that topic. I hope that came through. Long term, kind of coming down to this one. This is what we think about, and I think we probably are going to have space or time for one or two more questions. So drop them into the chat. Thank you. Reading my mind. Long term, when we think about where telehealth goes from here, right? If we think about this narrative arc, telehealth wasn't actually a thing. It was this, well, there's this cool thing that nobody's using, nobody's paying for, and nobody's allowed to use before COVID. COVID came. COVID kicked down the doors on the regulatory analysis and barriers. COVID, it solved the reimbursement challenge for a little bit. People used it. They liked it. Physicians liked it. APPs liked it. Patients liked it. Provider organizations liked it. Payers liked it. The question is, where does it fit into the future? Our answer at the advisory board is it is here to stay. From a provider institution perspective, it is a must not lose, right? You must have something. From a payer perspective, most payers, especially when they think about, if I am a large payer of healthcare, I get most of my money from employers of patients. Employers now want their patients to have access to telehealth. So those employers are saying, hey, I need you to have a telehealth offering. Payers may not go to provider organizations for telehealth, though. They may go to vendors, the American Wells, the Teledocs, the Livongos. Oh, actually, it's Televongo now, they just merged. But they may go to those institutions that have come together and, the Doctors on Demand, MD Live, just the vendors that provide telehealth services, if they do not have a provider partner that can deliver on those telehealth pieces. There is a lot of uncertainty in this future, but there's also a bright future for telehealth, both for the patients, for physicians, for payers, for care delivery, for suppliers, for communities. The thing that I would advise someone who was working on telehealth is this, right? Especially if you're in a provider institution, is from a what is inside your control. And I'm not sure if I'm going to pronounce the name correctly. I'm going to say Touchoir. I think this is probably a slide worth taking a picture of. I'll also make sure you get the slides and follow up. But this slide is also probably a good set of guiding principles for how RPM is going to be rolled out. If we have a defensible strategy for how we want to use this, what business goal does it solve? What clinical skills do we need? What are our patients interested in for this particular thing? And where do we want to end up, right? We don't want to swing the needle too far so that care quality across the country decreases because we have made it all virtual. Virtual and in person are still not the same. There are places where we can do virtual better than in person, but there are still places where in person is going to trump virtual. I'll give you an example. A colonoscopy, I'd rather do that in person than done virtually. It takes 4 people and there's a scope versus virtually. I don't think I'm going to do a colonoscopy. So there are places where we're going to find the right balance. We're going to find that equilibrium. And we need to set some form of reasonable target that we're going to keep it. We're going to have it as an industry in our individual institutions, and we're going to use it as a tool. We're going to have a problem we're trying to solve with it rather than have it just be a strategy. This gets that subtitle there, I think, is really impactful. Don't ask what your telehealth strategy should be. Think about how you can use telehealth to execute your strategy or to solve a challenge in your strategy. I have seen no new questions come in, but this will lead us to my final slide, which is the 5 points that we started with. If you remember nothing from today, and I would love to take another question or two if folks want to drop them in. If you remember nothing from today, it is these messages. Telehealth is much more than virtual visits. It is here to stay. Across the industry, we think it is here to stay. Patients like it, docs like it, payers like it. The question is, who's going to be the winner and loser when it comes to telehealth? Our advice is you got to not lose, right? You got to at least make sure that what you're doing right now from a provider organization perspective, from an employer perspective, from a community perspective is using this as a tool rather than letting it pass you by. The regulatory and reimbursement challenge are very real. We don't know what the future holds, but we do know that the future holds something. I mentioned very recently, telehealth is not a strategy, but it can help us with almost all of our strategies, be it access or be it serving underserved populations, especially if we're doing virtual visits via the phone. And this last one is, now is the time when winners and losers will be determined. And if we as an industry, whichever stakeholder of the industry you represent or you are interested in working with, if we don't do a good job, someone else will. And that will be, I will end with that. Those are my main messages to take from today. I hope folks at least learned something. I am happy to take a couple of more questions. Yeah, thank you for your time. Myra, I see you unmuted. The advisory board estimates of,
I think Mark has another question.
yeah, it looks like Mike's comment. The estimate of 10 to 30% of care being amenable to telehealth, broadly defined to including RPM, is quite low. And that is a great opportunity for clarification. We do not categorize RPM as part of that. When I think about those, I would say it's like the types of visits we know how to deliver today, delivered virtually. So think virtual visits. I would not throw RPM delivered in as part of that 20 to 30%. RPM has robust potential across a ton of other applications. We don't even know what we don't know there. The markets for it are very robust. There is also a ton of demand. I recall, I think it's 50% of patients have at one point in time or another downloaded either a app or a solution that would allow for some form of clinical information exchange. If we go from everything from Fitbit to a CPAP machine that feeds things back, there is a ton of room there. One of the big lines I sometimes think about is like, with what technologies we now have today, how would we reimagine how we deliver healthcare? If we took RPM and telehealth and everything else and said, okay, let's look at healthcare now with a set of solutions and redesign the system, what would it look like? I don't know that I think it is exactly what we have today. I think there's a lot of room to reimagine this system. Cool. We got 1 minute left. Thank you so much for the time. Thank you for the interaction virtually. I hope everybody has a great rest of the day and a safe December.
Thank you, Daniel. That was fantastic. And you will be giving me the slides. If you want a copy of the slides, please send us an email at groundcontrol@liftoffpgh.org and we will get them for you. Today, this was our last session in today's programming. Just as we hope, Daniel, you'll bear with me a second while I close us off. As well as next week. Tomorrow will be our second to last day of on-demand programming. We have a wonderful presentation tomorrow by Highmark's My Wish for Moms program. Many of you probably have seen their work they did with Chrissy Teigen. It's a pretty cool project around reducing maternal depression. So check that out tomorrow. There's a brain break. Also Monday, there's a great session from PNC around financial health wellness in regards to healthcare. And then please do, mark your calendars for our December 15th live broadcast. It's going to be a full day of awesome speakers and our interactive workshops on the 16th. And do share your experiences online, tweet us, get the conversations going, keep the conversations going. So with that, I hope everyone has a wonderful night. Stay safe, and we will see you at our next Lift Off program. Thank you, Daniel.